All right, thank you for staying with the Monday Report. It's time now for the Town Hall conversation, and we're talking about the Kenya Demographic and Health Survey 2022 report. Very interesting things that came out of there. But first, let me introduce my guest before we get into the details, starting from my immediate right, MacDonald Obudo, Director General, Kenya National Bureau of Statistics. Thank you so much for making time. Betty Sungura is here, CEO, National Gender and Equality Commission. Asante sana for making time. Dr. Patrick Amoth, Acting DG, Ministry of Health. Thank you so much for making time. And Dr. Mohamed Sheikh, Director General, National Council for Population and Development. Thank you very much for making time. Now, there's an entire 660-book report of the Kenya Demographic and Health Survey. Before we get into it, let me give you the context of what this is all about, all right? Then we'll discuss.
The Kenya National Bureau of Statistics, in conjunction with the Ministry of Health, National Council for Population and Development, National Gender and Equality Commission, development partners and other stakeholders, conducted the 2022 Kenya Demographic and Health Survey. The 2022 KDHS is the 7th to be conducted in Kenya and is part of the international series of demographic surveys, which are nationally representative household surveys. The primary objective of the 2022 KDHS is to provide up-to-date estimates of socio-economic, demographic, health and nutrition indicators. These indicators guide the national and county governments in planning, implementing, monitoring and evaluating population and health-related policies, projects and programs. The first KDHS was undertaken in 1989 and subsequent ones in 1993, 1998, 2003, 2008 and 9 and 2014.
Currently, if you look at issues to do with rural-urban migration, it's the youth who are moving and leaving behind the elderly population. So how do we plan for that kind of movement in urbans? We require housing, we require job opportunities, water and sanitation. So just to understand and plan in ahead, so that you're not caught off guard by the time you just have slums and other things and shanties coming up.
For example, we want to track how mothers are delivering in hostels, how many of our children are getting immunized, how our children are getting fed in terms of nutritional status, our HIV indicators in terms of performance, what is the infection level, are we on track, what is the knowledge, how many Kenyans have been tested. So a broad range of indicators are assessed.
The findings, therefore, are able to help in planning in order, if it's an adverse issue, to see how then the adversity is reduced. Or if it's something that's prevalent, can the prevalence rates then go down? Or if it's something that needs to be enhanced, can the enhancement be visible?
The 2022 Kenya Demographic and Health Survey planning and implementation involved establishing committees drawing membership from various ministries, departments, agencies and development partners. These committees are the Secretariat, the Technical Working and Steering Committee. Activities to undertake the survey comprised of development of survey tools and instruments, pilot survey, training, publicity, data collection, data processing, data analysis, report writing and dissemination.
DHS majorly is consumed by the Ministry of Health and also the National Council for Population and Development. But there are other users like the National Gender and Equality Commission, the State Department for Gender and Affirmative Action, and many other stakeholders. And so in the process, we would bring them together. As the coordinator of the National Social System, we are meant to bring users together.
The current government is going to use the 2022 KDHS indicators as a benchmark, and therefore, from the results we are getting, they are going to come up with policies and the guidelines to be able to improve on areas that are not doing well, and also find a way of maintaining what has been achieved as at 2022.
Based on the indicators from previous demographic and health surveys, the government has developed interventions targeted at improving the health and well-being of the people of Kenya.
More of our children are seeing their 5th birthday. If you look at the figure for this year, out of 10 children born, 6 are able to see their 5th birthday.
The marginalized and minority groups, they're now able to own land, they're able to access their land rights, Those are provided for in the Constitution. They can take up leadership roles because they are now more empowered. They can take up positions of either any of the 6 elective positions we have in Kenya.
We look at issues of our life expectancy. I think our life expectancy right now we're talking about is an average of 64 years. Look at again our child mortality, infant mortality, maternal mortality. All those indicators have gone down, and we have reduced child mortality, infant mortality, maternal mortality.
All right, and that is the conversation we're having right now. Send in your views at Trevor Mbija at Citizen TV Kenya. Use the hashtag daybreak, no? Monday report. All right? It's not tomorrow yet. It's still Monday. Right. So that's the conversation we're starting. Obud, I'll start with you. What stood out for you in this report that I'm holding here with me?
Thank you for the question. From the statistical point of view, I took note that the results that we managed to get from this exercise is that they have been very consistent. They are consistent with what we have generated from the population and housing census, very consistent with what we have been able to get from the administrative data which we publish in economic survey and a statistical abstract. And so data really does not lie. Figures do not lie. There's a lot of consistency in the indicators that are cutting across the censuses, surveys, and administrative data. And the good thing about what I can say in general from this report is that most of the indicators are showing very positive trends in terms of what is required to go low is really going low over the period. What is meant to, the indicators that are meant to go high are actually going high, and so things are very positive.
Yeah, but how reliable are the results?
Well, the results are very reliable. You know, first we are coming from a point of the coordinating agency on the national statistical system. And so we are able to bring together the users and producers of statistics. And when you look at the lineup of the team that has worked on this particular report, you will be able to realize that they have been, we have key users. Ministry of Health is there. National Council for Population and Development is there. We have the National Gender and Equity Commission. We have the State Department for Gender and Affirmative Action. We have KEMRI. And then we have also brought on board a number of development partners who have interest in different thematic areas. And so the process was designed in a way that we had a technical team that was represented by all these institutions that I'm talking about, including having the steering committee. In fact, the 4 of us who are here are members of the steering committee that has steered this process, together with other more who are not here with us. Now, we develop the statistical infrastructure that would help us do surveys.
Yeah.
So first of all, we have the new frame, statistical frame that we are using currently, which then this survey benefited from. We also have, we are also able to design, come up with a design and a methodology that is suitable for this kind of an activity. And this was also contributed by all these players that that are coming together at different levels. Yeah. And of course, the training itself, the way the training was done. It was 28 days of training of the people who are going to collect the data in the field. And that is after training the trainers who then trained them. Okay. So then we were able to pilot it. We were able now to go to the field and undertake a survey from 17th of February to 13th of July. A long period of time, and in the process of doing so, we were able to have a lot of monitoring of the survey personnel. So the supervisors were able even to interact with the research assistants in terms of checking on the quality of information that they were collecting. Okay. Transmission of the data from the field, because it was digital, transmission of the data was actually very smooth, and analysis was done in a centralized point, having all technical staff coming together to do that. Yeah. And so when you look at the whole process of what we went through, then you would be sure that you would be able, one should be able to trust these results as they are given.
Okay. Yeah. And Sungura, let me come to you on this. What stood out for you, first of all, before we get into the details?
Yeah, I think what stood out for me most is Kenya has now made strides. Reading this report, you see several gains that we have achieved. Kenya has signed several instruments, at international level. The Convention on Elimination of Discrimination Against Women. We are now really active in the Generation Equality Campaign. We want to ensure we have FGM eradicated by 2030. We've given so many commitments. So when you look at this report, you see the strides when it comes to women empowerment, bridging the gender parity gap, and there's more hope when you read this report. Yeah. We are not back where we were in the past. Like in the last KDHS survey that was done, and looking at this survey, you can see quite some strides. You can also see a population that is really out there to make decisions. Whether they're good or bad, they are making decisions, And therefore, I think for me, it spells quite some very good hope going forward. And it also is able to inform several policies, programs, if you need legislation in some areas in order to bridge certain gaps. Yeah. I mean, this report really stands out for me as a progressive report.
Yeah, Kenya's made strides, you say, but let's talk about ownership of assets, for example. Are you seeing a positive relation to that in regards to gender parity?
Yes, well, comparatively to, if you look at the men and the female gender, there is more men, for example, owning mobile phones, and that's already stipulated in the report. But what does that tell you? That indeed, even though there are more men, still we also have women at a high percentage, like way over 70% with a mobile phone, and many able to access digital platforms within the phones, even to open bank accounts and therefore transact digitally. So this tells you that, yes, indeed, when it comes to asset ownership, there is a stride. If I talk about land ownership as well, there is also some stride, though not much, right? And I know we have many decisions, even of the judicial, of our courts, which have actually informed more about land ownership for women. Okay. But you can see still it's a dismal percentage of women who own land or even homes compared to the men. So there's still some work to do there, probably to empower them more, to give them more information, to open them up to spaces where they can also earn income and be able to buy these properties. So there's quite some work to be done. But of course, like I said, some progress compared to the last. Because again, this report does compare the data in the last KDHS and this one. So you can see areas where there was improvement and areas where there's still work to be done.
Okay. Yeah. Dr. Moth, for you, what stood out and why is this important for the health sector?
Very important for the health sector, Trevor, because literally all indicators in this report either directly or indirectly impact health. And what stood out for me is, of course, the solid performance. And therefore, this is an affirmation that devolution actually works. Because if you look at this data is collected over a period when we operated the devolved system. And if you look at the progress that has been made from 2014 to now, it is more rapid compared to the previous Kenya demographic health surveys. Therefore, decentralization has made a huge impact. Of course, what also stood out, of course, is still the disparities and inequities, especially that affect the northern arid lands. If you look at the performance of Wajir, Mandera, Turkana, Samburu, again, in most of the indicators, they still lag behind, and therefore will need concerted efforts collectively as a people to ensure that in our journey towards universal health coverage, then we don't leave anybody behind. Because of these shared opportunities, shared responsibilities, and shared prosperity, it is imperative that we work together with counties that are lagging behind in certain indicators to design interventions to ensure that they are brought to par in terms of performance of the rest of the country. Okay. So very credible results, and we are quite excited about them.
Okay. Dr. Sheikh, for you, what stood out?
Trevor, for me, I think two things.
Yeah.
One is the magnitude and the robustness of this survey.
Okay.
You know, we have surveyed over 42,000 households with 98% response rate. So I think this is a massive, what you call, survey. And it's a survey that you can say is a very reliable. I was part of the team that, you know, had some field visits.
Yeah.
And you can just imagine, you know, when I visit those households, you know, the time that, you know, the survey team was taking just to spend, you know, with one household. There are around 4 questionnaires, and, you know, it was a very robust question. But the other thing that stood out very clearly for me is the issue, is the progress that we have made as a country. You know, as my colleague have said, we have made strides. We look at some of the commitment we have made in terms of the SDGs, our Vision 2030. I think as a country, in terms of maternal health, child health, newborn, and many of the health indicators, we have made progress. And as a country, we need to be proud of this investment that we have made and the results we have achieved so far.
Yeah, but Dr. Sheikh, is there a correlation here? We were reading through and we saw Kenya's fertility rate has declined. And also, there's a result of women now who had 7 children in 1989 now are opting to have 3.4 children per woman in 2022. First of all, what is 3.4 children? And isn't it supposed to be either 4, 5, 3?
Yeah.
So,
how do you explain that 3.4?
So generally, this is a ratio, or a rate, where we use and we calculate, you know, the total children a woman will have in her lifetime if she lives, you know, fully up to her reproductive age. That is from 15 years to 49 years and above. So Kenya, this fertility rate has dropped from 7 in the 1980s to now 3.4. In fact, the fertility replacement rate, what we call the replacement rate globally, is 2.1. So 3.4 is a very good figure. Our target was factor 3 was 3.5. You know, we used our targets of the population policy. The population policy that we set in 2012 our target was 3.5. So a rate of 3.5 really is a great achievement. But this one is, you know, looking at our population growth. If you look at our population growth in the 1970s was around 3.4% per annum. Right now we're talking with this reduced fertility rate, a population growth of 2.1%. And, you know, this is in tandem with to see how we can have a population growth that is in tandem with our economic growth. So this is not something that should worry Kenya, that our population will still continue to grow in the near future for the next 50, 100 years. So this is a very good performance for our country. And globally, generally, there is a trend that there is a reduction or a decline in terms of fertility rate. Yeah. And this is something to do with, you know, issues to do with the socioeconomic factors, issues to do with education, issues to do with access to reproductive health, and many other factors.
So it's not entirely a medical issue where fertility rate is going down because of lifestyle or something like that?
No, it's not only that. It's just, you know, also it looks at, it's more of the changing world lifestyle.
Yeah.
That where women are, you know, getting, you know, or getting children in the later stage of their life, where education also plays a role, that because of women empowerment and many other things. So generally, 3.4 fertility rate is a good performance for this nation.
So the population will not go down?
Will not go down. That's when I can assure you our population, because of our population base, we have a very youthful population as a country, and our population will grow for the next 50 years.
Okay. Yeah. And let's talk about another issue here, housing characteristics, and the proportion of households with electricity increased from 36% in 2014 to 51% in 2022. Does this relate to an increase in resource capabilities of households, or is connectivity not related to anything to do with affordability?
No, the government is making efforts to ensure that as many Kenyans as possible get the electricity services, because then the effort is also made to ensure that we move away from something like usage of wood fuel. Yeah. We need to be dependent more on the renewable energy. And so this is what the government is actually trying to ensure that we get there. So first of all, moving from 36% to 51% from 2014 to 2022 is already a great improvement. But of course, as we go along, Kenyans are also making efforts to ensure that they get that connection. And so then the power providers have also made it possible for many people to get it. You don't need to have all the funds required to have the connection. You know, something that you can pay over a period of time. Yeah. That has also made it improve. So even for somebody whose lifestyle, whose income in 2014 is still somehow the same now, you are able, given the choices of how to get connected to electricity, you will be able to do it over a period of time and get it. And so that explains why we are making progress. Of course, if you go to what Kenya Power reports, they're using they're looking at the number of connections, not linking them directly to the number of households, and so you'll find that their figures are higher. But here, for the survey, we confined ourselves to the definition of a household and which ones have connection, which one did not have the connection, so that we could analyze the use of electricity in terms of cooking, in terms of lighting, in terms of heating, and so then we are able to see that there is some good progress made so far. Yeah. Yes.
Okay, and something that Sheikh also touched on somehow is the household population. Results released were showing that 40% of Kenya's population is under the age of 15.
Yeah.
What does this mean for the country?
Yeah, you know, this is a population that, first of all, it means that Kenya as a nation is a youthful nation, because it has very many young people being the largest, taking the largest share of the population, and so what it means is that look at that age. You are talking of those who need to go to school, right from ECD, primary, secondary. Then you would need, then of course getting to the university. So then you would also want to look at this population that beyond today, if I add one more year, everybody's adding one more year, and another one. So then we are moving to a stage where we also require employment. You know, at the end of the day, we would need to, once we finish schooling, then we would need to get employment. So it is putting the government in focus to ensure that we provide the basic needs for this young population that cannot fend for itself. Yeah? And so you look at it in terms of health, you look at it in terms of education, you look at it in terms of other services that the youth would require, which has to be provided to them. Okay. And this is something that now has to put the government on the alert that we have a big responsibility to deal with as a nation or as a government. Yeah. And of course, the responsibility is not just the government, but all of us collectively. How can we support the youth? And you know, you are able to see that a number of them have actually gone to school and they are not able to get jobs immediately. Now, it is a situation that we as the runners of this country, we need to get to see how best would we engage them so that they become more productive. Okay. Yes.
Speaking of productivity, Betty, and I see on the issue of employment, you reported that 67% of married women and 98% of married men aged between 15 to 49 were employed in the last 12 months prior to this survey. How is this statistic important in regards to women empowerment? And what are you seeing? Is it on the positive or is it on the negative?
Yeah, well, I see positivity in this. Yeah. I see the gap having been breached to a large extent. I know there was time, like if you look at the last KDHS report, the ratio was larger, right? But of course, we have the men at a higher percentage than the women, meaning gradually we are having more women in economic participation and being able, of course, to, and that, of course, then now gives you reasons why. We aren't at the same percentage as the men, but of course there is more enrollment in school. There is more awareness creation, and that's the reason why they can, of course, plug into the employment space. And that also tells you that there is much more work to do. And for me, it's actually a paradox, because now we're hearing about the boy-child issue, but again, here we have more men in employment than the women, all right? So you're like, okay, fine, so do we really have this boy-child situation, or is it just a mirage of what people think is really happening? But for me, it actually spells too much more work to empower the girl child all the way from education to employment, as opposed to just having, and also, let me just say this, following up on the dropout cases.
Yeah.
Are we having more women dropping out either at primary level, at secondary level, at tertiary level, and not able to complete the entire education cycle? And therefore, that's actually food for thought. But I think it spells much more to some improvement and progression, because again, in the same survey, we have 96% more women who are cash earning, able to make their own decisions.
Yeah.
Of course, therefore earning more assets, earning more financial control, and therefore being in the economic space, of course, being able to plug into the small and medium enterprise solutions. And therefore, I think its progress could be better, but I think we need to achieve, celebrating our strides as well.
Yeah.
Yeah, look at it from a positive perspective too.
But are you seeing a direct relationship between the resource availability, economic empowerment, and decision making? Is it directly related that most who are empowered economically are the ones who end up making the decisions in the family? Because we've seen also 34% of households are run by women. Is there direct correlation to that?
Yes, indeed. Actually, an empowered woman
Yeah.
is able to sit in a space of decision making as opposed to a disempowered woman. And therefore, these statistics that we are seeing and the indicators that we had in this survey, the gender indicators, were able to give these outputs that we are now discussing. And with more women now being able to even get mobile phones, like I said earlier, reason they're able to have income to buy these gadgets, then they're able to even do M-Pesa transactions and get into investment opportunities. Obviously, therefore, I know with the advent of COVID, because this survey was done during the advent of COVID, we're able to find, like many households actually, men had lost their jobs, and therefore women were running the show. This therefore tells you that we have a lot more women in the SME sector, and we're able then to stand in the space of being decision makers in homes.
Okay.
Yeah.
Dr. Mott, there's something that people always talk about, and it's also in this KDHS report, of the number of sexual partners that people have. Why is that important from a health perspective?
Thanks, Trevor. Before I get to that, let me just chime in regarding the previous discussion you had with Dr. Sheikh and DG KNBS about population. That youthful population is actually a big asset for this country. If you can be able to tap into it by providing the necessary support for them to be able to get the right education, put in place the right policies, economic policies in terms of financial access, and the other infrastructure that you need to put, then we can be able to achieve as a country what they call the demographic dividend. So that currently, if you look at our population pyramid, the bulk of the population is at the base. We have a wide base, which tapers towards the apex. So these people at the base and the people at the apex are the people who require to be supported. So we want to change that scenario to make it bulge a bit in the middle. So we have a bigger population, a bigger number of people who are in the workforce and productive, and then can be able to support the young, youthful population at the base and the elderly at the port who require social support. So what we require to do is just to be able to put in place good policies and programs to support the youth to be able to grow and achieve their potential. You have seen the powers of this world, the Chinas, the Indias. One of the things that they have, even America is actually a population that has, if you look at countries with huge population outside sub-Saharan Africa, most of them have made significant progress. But to return to your question, critical that we ask that question because sexual behavior we ask that question because sexual behavior, information, data on sexual behavior help us design programs for, or interventions for prevention, monitoring and implementation of HIV programs. Yeah. So we ask that question so that we can be able to see what can be able to work for us, and therefore it is very, very important. And this particular KDHS, what is surprising is that if you look at the data that is in that book, if you look at the people who have had sex outside their spouses, or those they cohabit with, it is 2.3 for women, 7.4 for men. And if you look at the condom use outside that, during that episode, again, 39% of women used condoms, and 68% for men used condoms. So it is very important for us to be able to have this data. For example, if you are dealing with the youthful population, where now we are having increasing cases of HIV because of the youthful nature of the population, the risky sexual behavior, then this data can be able to inform us in terms of the programs put in place. And from that data, again, you can be able to see that women perceive themselves at a lower risk because they are having sex with not their usual partner, but they are not using protection at 39% compared to men who are using protection to the tune of 68%. Again, if you look at that data, it clearly shows why then we have a bigger problem of HIV disease in women compared to to men, meaning that probably women have a lesser bargaining power in terms of how to negotiate for safe sex. Yeah. Again, this data now is what we have used, like now for the youthful population. If you maybe you have heard of this slogan, undetectable and transmissible, that if you are a young person or any other person with HIV and you take your treatment and you cannot be able to detect the virus in your blood, then you are unlikely to transmit the infection. And other programs that we have put in place to be able to protect the youth, because out of that information is only 6 out of 10 youths who have correct information on HIV prevention. Yeah. So leaving a huge population of 40% of the youth, and yet you have said on the flip side that 40% of our population is the youth. Yeah. So a big population at risk of contracting HIV disease. Yeah. And therefore it is because of that we sit down together with our partners to be able to design interventions, including demand creation, self-testing, formation of peer groups so that it can be able to support use of social media platform to be able to reach them, use of robust data systems, so like this one, which can be able to generate credible data so that we can be able to frame interventions from such credible reports.
Yeah, but obviously this is a very sensitive subject, especially when you bring it up to households. Are you concerned of the authenticity of the data? For example, I'll take a look at Kericho. Kericho men who have 2 or more sexual partners are at 2.2%, second last. But women who have more than one sexual partner in Kericho is at number 2 of the highest, at 6.5%. So who are they cheating with?
Trevor, I will not take it from that direction. In fact, we are watching the clip of the news at 9 o'clock when we are waiting for this interview. Yeah. And that entire report was reduced to about number of sexual partners and polygamy. Yet that document has a lot of data that is very, very crucial for this country. Remember that the figures that we are talking about refer to lifetime number of partners, not current partners. Okay. And Dr. Sheikh has told you about our life expectancy, 64 years. So assuming age of sexual debut is maybe 15 years, so 15 to 64. So it is that entire spectrum of time. It is not at that particular time when the survey was done. I think that distinction is very, very important to bring out.
Okay. And Dr. Sheikh, I'll bring in on this. Despite the declining fertility levels that we're talking about, and you said that we are at a good space, it's not so much declining compared to global figures, why do some counties such as Mandera still have what is perceived as high fertility in terms of 7 children per woman, as compared to Nairobi, Kirinyaga and Kiambu, which have low levels?
So, Trevor, just, this survey is a survey that we do after every 5 years. Yeah. And in our country, we have 5 years plans. So this survey is just to do an assessment and the impact of our investment. So, when you look at the indicators that we have there are very many indicators, from child health, nutrition, immunization, reproductive health, household characteristics, and many of them. So I think the issues about the number of partners is just a small bit of it, but as Dr. Ahmed has explained, is just to show, the exposure to or risk to diseases. And I think that should not be taken out of context, because it is an area that for us, in this domain, we want to find out how the behavior of our citizens so that we can make the right interventions. Coming back to Mandera, in this survey, there is some disparities across the country in terms of many indicators. And in particular, when you look at issues to maternal health, child health, issues to do with teenage pregnancy, and there you have mentioned issues to do with fertility. Fertility, mostly it goes with the level of education. And counties in the north, mostly women are not, the literacy level is very low. in terms of education, I think it's also very low. So those are the factors that may drive, and that's why you have high fertility level. Again, other issues are cultural issues that drive probably large family size. Probably in the north, they prefer that one. But generally it's something to do with women education. They say the best contraceptive is education. So once we educate women, I'm sure the family planning level will go up and the fertility rate will also go down.
Yeah.
But other issues to do with, again, is access to healthcare. In these areas, probably the access to reproductive health services is minimal, and that's why probably we have a low contraceptive prevalence,
yeah,
and high fertility rate in that region.
Okay. One of the positives that Betty also touched on was the teenage pregnancies. They've simply declined from 18% to 15% between 2014 and 2022. What are some of the efforts that were made to achieve this decline, and what more should be pushed so that is it possible to eradicate it completely? So again, issues to do with teenage pregnancy is again another issue of a concern in terms of population issues, because it is, the age that is that's affected most, especially the girls who are aged below the age of 19 years. This has declined from 18% to 15%. There's a bit of a progress in that. But generally, again, when you look across the country, there are counties with 50% of the girls, with 50% having either had pregnancy or are pregnant. Some counties like Samburu, Meru, West Pokot, Marsabit. So these counties also have high teenage pregnancy. And the consequence of teenage pregnancy is that girls of that age are not prepared, physically, mentally, biologically, and it ends up with high maternal mortality, high child mortality, and that's why, as an institution, we have put efforts to reduce issue of teenage pregnancy. During the COVID, I think this issue came up. It was a really something that was discussed across the media houses. The National Council for Population looked and had meetings with the various institutions, and we realized that this is a very really challenging, is a complex issue, because when you look at teenage pregnancy, it has an health repercussions, it has a social repercussions, it has economical issues, it has educational issues. But then when you look at as a country, the way we coordinate this program is that health are only dealing at the number of cases that have either reported for antenatal care, the number of cases that have died in the fertility ward at that age group. Education, they're looking at the aspect of those who dropped out of school and did not come back to school. And then when you look at the issues of the Ministry of Gender, they're looking at the issues of only gender-based violence. So we just said, how can we have a multi-sectoral approach as a government? And then we coined a program called Ending the Triple Threat. So looking at issues of ending teenage pregnancy, HIV, and the gender-based violence. Yeah. And then as a government, together with now the State Department of Gender, together with the Ministry of Health and other agencies, including the NGAO, we started that campaign. And I can see, the intervention that we have done for those years. I think we can see the result that issues of teenage pregnancy has gone down. But I think still 15 is high, very high. If we translate that one into the number of girls who get pregnant in the country annually is more than 300,000 of that age group. So it's a very high figure. Still, we need to really do a lot of efforts and heavy lifting in terms of reducing teenage pregnancy in the country. Okay. Dr. Amot, I know this one you deal with directly. So what is the missing link here?
The challenges, as have been highlighted by Dr. Sheikh, multiplicity of factors that contribute to teenage pregnancies. But one of the things that we really need to know, and we can be able to deduce from this data that we have received today, is the importance of keeping the girls in school. School is the best corridor to be able to protect girls from teenage pregnancy. And if you look at the multiplier effect of girl education in most of the indicators, it is monumental. So this will require a multi-agency kind of approach to be able to address from all angles, because a variety of reasons lead to these teenage pregnancies. And some of the reasons are cultural. If you go to places like Samburu, is those cultural practices where the girl is beaded, and once you are beaded, then you are ready for marriage. I mean, you have to be able to discuss with these people so that we can be able to change that. You are marrying children who are not ready for marriage, even though it was your culture. And I believe you can be able to do this. If you look at the data that was released today regarding male circumcision, traditionally there are communities in this country that don't circumcise. So the Luos don't, traditionally, the Turkanas, the Tesos. But now, if you look at the global figure for the country, 94% male circumcision. So we can be able to initiate this dialogue with these communities to be able to have a narrative, to be able to change their perspective. Issues of poverty, if you go to the Lake region area, especially the effects of HIV/AIDS, you have households that are being led by children who are very prone to exploitation.
Yeah.
And you find most of them don't even go to school, and therefore if somebody can be able to give them support in terms of 50 shillings or something like that, then they can be exploited. They not only get pregnant, but they also get HIV in the process, or they get sexually abused in the process, or a combination of all those factors. And therefore, it will require approach. Progress has been made, yes, and we need to be able to revisit this more and more so that we can be able to bring the numbers down.
Okay.
It is a real blot on our face as a country.
Yeah, Betty, this too falls in your purview as well. So what do you suggest?
I just want to also add to this that I saw a very worrying report recently in the mainstream media, which basically was titled, Is Kenya Becoming a Pedophile Playground? And that report really concerned me because first and foremost, at the onset of that report, they said some very good news here, that the Kenyan judiciary, of course, led by Honorable Justice Martha Koome, had already opened our digital register so that we can have a permanent record for these predators or whoever now who are found to be culprits. They'll be permanently in those records, and therefore they cannot be at bay out there ready to again prey onto young children. But what worried me most is that we are having high numbers of online child sexual exploitations, you know, and Kenya is actually on the high. And it's something that we need to look at, because I know, and we all know, that the youth can now access these gadgets at any time, 24 hours, right? And these rewards being given online for nudity, all that exposure, and even actually having live sex for young children, and they're able to get some rewards. So I think it's something that really needs investigation in order for us to save our young generation. We're talking about 40% being the youth. And if a big portion of them are engaged in this kind of very risky behavior, what then are we saying about the projectile for this country going forward? Yeah.
And let's talk about two issues here, health insurance and registration of births. So the National Hospital Insurance Fund is the most common type of health insurance, and we have also seen now 1% of the households have community-based health insurance coverage. First of all, what entails community-based health insurance coverage before we talk about NHIF?
Okay, before I get there, there was the concern about the Kericho issue. Something that is not able to be explained in one study, it opens up chance for another study again. Now, to unlock what is not clear in what a survey has revealed. And so, for your concern about women and men in Kericho, it is something that calls for finding out what brings about that the differences that cannot really be properly explained. So there is a chance to have that one done, and of course what was reported is based on the data that was received, and of course there's a lot of scrutiny that is done before anything is published. So it is correct as given, but then we are also planning to undertake further analysis of what is contained in this report. And that is actually going to be led by and coordinated by the National Council for Population and Development and the DGs here to deal with it.
Will that also cover why Narok men seem to have multiple partners?
Once we get through the report, then we realize that there are certain questions that we are not able to there are some trends that cannot be explained clearly. Then it will call for other means of unearthing the details. Of course, some of them will not be done through just the further analysis, but they would require standalone surveys to understand them. So then back to the issue of the health insurance cover, and we are talking of the 1% of
community-based health insurance. What does that entail?
Yes, just like you have nowadays the case of benevolent covers that a group of people will come together, contribute, and then go, buy a premium in an insurance firm to cover them such that in case of death to one of the members or one of the kin to the members, then there is the benevolent benefit that is given. It's the same way that this insurance cover works. So the question that was posed tried to establish all forms of insurance covers that people can have. And of course, the major one that was turning out to be common is the NHIF one at 24%. Then we have the private and commercial cover, which was 4%, and then we have the community-based insurance cover at 1%. Now, this 1% is arising from the fact that in a community, people would come together, they contribute, and from that contribution, they go buy the cover for themselves. So then there's another group, in another scenario, where the same group of people would contribute within a community. It could be a village, it could be a larger part of the village, it could be even a small, just a portion of a village or a wider area. They would come together, contribute, and make the savings. Have a kitty that they're intending to use anytime any one of them falls sick. Yeah. So if a member falls sick, they draw from that kitty and pay for it. So that is what is reported as 1%.
Okay. And there's something else that caught my attention here: registration of births. So from the 2022 KDHS proportion of births registered in the country is 76%. Yeah. So are these results comparable with what is provided by civil registration services, but also 24% are not registered? What does that mean for population totals? Are we having the accurate figures if only 76% are registered?
Yeah, first of all, there has been great improvement. Yeah. For us to get to the 76% that that the survey has reported, for some years we stagnated at between 56 and 60%. Of births registered, but you can now see we have moved to 76 as per the report. And what happens is that in the process of when a birth occurs, it can occur in a health facility or at home. I mean, or away from the facility. Yeah, and those that do occur in the facilities, they're actually registered immediately. They are notified. So that is a form of registration notification before we talk of the birth certificate itself. So then, for the cases that are not registered in the health facilities, there is a way of capturing them, and this is done through the administrators, the chiefs and assistant chiefs, who are also trained and given the right forms to help in doing the registration. Then they submit this to the civil registration services for compilation. Now, what happens is that in the census, for example, where we combed from one household to the other, and from each and captured cases for all the children, we got 80.6% as registration coverage. So you look at 76 point something and 80.6. They are not really very different. Wow. What makes the difference is the methodology, and at the same time, for the civil registration to report their birth registration, it is based on the expected number of births. And that is coming from us, from the Bureau of Statistics, because we are able to do the projection from the census. We are now able to do the projection of how many children are expected to be born for a particular year. So for that year, we are able to give them the expected number.
Yeah.
So they are now using that expected number as the denominator.
Okay.
for the calculation of the percentage of births registered. So it is. So first of all, it is coming from an estimation. Okay. Yeah. So it's a question of the methodology that would make the figures be slightly different, but they are very comparable. Okay. In fact, if you now inject the element of sampling, sampling errors to what is given in the report, you'll be able now to see that statistically what is reported in the census and what is reported in the survey are not any significantly different. Yeah. And what maybe you had not told Kenyans is that there is this report which is 660 pages. We are calling it volume 1, and there is volume 2, which is 404 pages. Now, volume 2 is now giving those element of confidence intervals. You know, it is looking at the standard errors, and so that when you are using this report, use it alongside the other one, so that you are able to see what are the differences. Are there any meaningful differences when I apply the standard errors that is related to this particular indicator and in this particular county, or at the national level, or at the urban or rural levels? Okay. So then that makes the complete, it will give you now the complete picture of what the situation is.
Okay. And Sheikh, speaking of deaths, registrations and births, the 2022 report also found that 38% of all pregnancies are either unwanted or mistimed. This then implies that many children are born in the country, they are not planned for by couples. What is the missing link here? Is it a missing link in terms of communication and education on reproductive health care, or what is going on there?
So, mistimed.
Yeah.
That means they were planning to delay, but then the pregnancy came early. And this is something to do with access to services, special reproductive health services, and also having knowledge of choices in terms of reproductive health services. So it's generally something to do with access to the family planning services, that women want to plan for their families, or want to plan for their child spacing, but then they don't have access to the services. And that's why probably it's something to do with the absence of those commodities or those services across the country. But the second thing, again, is something to do with the partners, relationship between partners, and communication between the husband and the wife in terms of, again, planning for their child spacing. So mistime is just that it happened, but they were planning to delay. Either one of them was planning to delay. So I think generally that's, but it's not something of a concern. Yeah. But I want to revisit the question that you asked about the Kericho and the Narrow. Yeah. This study is only giving us the what. And in policy making, there are 3 steps: the what, the why, and the how. From the what now we'll move to why. And our academia and other institutions now will take over. Yeah. So they will go to Kericho and find out, and now the university and others now will find out why is Kericho behavior like this. And from there, we will get now what we call the how, the policy interventions. So from here now we prepare policy briefs, advisories, interventions, both to government at the national level and the county government. So right now what we have is the what. Now from here we'll move to why. And from the why we'll move to the how. Okay. So there are several steps even after this. So I think, I want to stop there for that.
I know. But there's also another issue of mortality here, where Kenya has continued to register a decline in deaths among children below the age of 5 years. In 2003, about 115 children out of 1,000 dying before the age of 5 years. Today, this number has declined to 41 children. So what kind of interventions have been put to ensure that this is stopped or dealt with appropriately?
So I think that Dr. Amos will answer it very well. Let me just speak it first before I hand over to him. Yeah. I think that is the result of our programs, especially the maternal health programs. Look at our immunization. Right now, I think, Dr. we have more than 88% of our children less than under 5 years are covered, fully immunized. Look at our deliveries. Our deliveries also have, the skilled deliveries has improved. We were talking this morning about 88% of women are delivering in health facilities. So I think these figures have declined or are declining because of the interventions. The free Linda Mama program, I think the effect of that program we can just see in these results. And by the way, when you even look at counties that have really a very good healthcare service or programs, has shown, improvement in terms of their indicators. Even county-specific, we can just show the interventions that was done by the counties and the result of those interventions. So I think generally I want to hand over to Dr. Amoth, but generally something to do with interventions that we have done in our healthcare sector in the last 5 or more years.
Okay. Dr. Ari.
Oh, thank you. Yeah. Thanks, Sheikh, for adding to that. I think critically important, of course, is that 6 out of 10 children are seeing their 5th birthday, compared to 5 out of 10 in the 2014 KDHS, due to a number of factors, especially programs that we have put in place. One is, of course, the immunization program, and we have continued to increase the number of antigens of vaccines in the immunization program. One of the leading killers of children is, of course, diarrhea. And we introduced the Rota vaccine into our routine immunization schedule in 2013. We are now seeing the effects of that. The other one is treatment, how to treat pneumonia at community level. We can be able to treat pneumonia at community level. And one of the reports in this big volume is how mothers can be able to seek care when their children have fever or difficulty in breathing. Again, it is concerted efforts by the ministry and other stakeholders of advocacy of what to do when a child falls sick. Treatment of diarrhea using oral rehydration salts, which can even happen at household level. Again, very, very critical. Treatment of malaria. Now, many children are sleeping under insecticide-treated mosquito nets, and therefore protecting under 5 children from malaria. And also in terms of nutrition, new good nutrition habits, training of the mothers. When we start weaning, then you find that the children are well fed, their immunity is good, and therefore even if they fall sick, they can also be able to battle the infection. So a number of programs that we have put in place are beginning to bear dividend, as shown by this report.
Okay. Betty, we are running out of time here, but I wouldn't like us to close without talking about GBV. What did you find out on that, and what are the greatest intervention that needs to be put in place? Because I saw some really startling statistics.
Yes, indeed. There are high cases of gender-based violence. Yeah. And I think what's really unsettling in this report is the fact that those are cases within households. So you find these are cases where there's a husband meting out gender-based violence to his spouse, that's the wife, or an intimate partner relationship. So you find the cases are really high at that level. And I think what's also worrying is the fact that most of these cases are settled at household level. Really a high percentage of them, over 60% people resort to sorting this at household level, as opposed to even reporting to the police. And a few, of course, would go to the neighbor. So the how question, like what then now Dr. Sheikh has mentioned, this is the what, the how. The intervention here probably I can see being, why then can't people seek legal redress? Why would you sit with this mental anguish and go through GBV? Kenya has ascribed to even eradicating GBV by 2026, all right, because we are also cognizant of the fact that we are part of the Sustainable Development Goals, and arriving to gender equality by 2030 is quite a huge stride. Not many countries have already attained gender equality, but however, GBV has quite huge ramifications to a person and even to families and the society at large.
Yeah.
What again I found quite interesting in the report and the findings is the fact that more women at 43% compared to men at 35% would resort to various different isolated cases of having a woman hit by the spouse. And very interesting indicators were in the questionnaire, like for maybe neglecting children, not cooking good food. You know, there was such questions, and actually a huge percentage of women would say, yeah, it would be very okay for a woman to be beaten. So that then takes you back to, is that a stigma issue? Is that a societal construction issue where people then believe that wife beating is still a norm, and therefore trying to get them out of that through awareness creation and also more and more campaigns around GBV being quite a retrogressive culture.
Yeah.
Yeah.
And Dr. Muda, let me bring you on this. There's something I'm reading on page 12 here that is a bit interesting. In Turkana County, 75% of the population falls within the lowest wealth quintile, while in Nairobi City, almost no one does. In Nairobi City County, 71% of the population is in the highest wealth quintile. So most of the poor households are in Turkana, and most of the wealthiest households are in Nairobi. What did you use to get this data? How do you decide which is a poor household, and how does the other counties then rank?
Yeah, now the wealth quintile that we came up with was based on the household goods and amenities. You know, in the process of doing the survey, we were capturing what the house, what material is used to make the floor for that particular household, what is used to make the wall, what is used to make the roof, and then within it there are a number of electronic gadgets that we're also looking at. There's the TV, there is the mobile phone, and the like, the sofa set, and a number of household goods that were actually considered. And so then, for you to get the quintile, normally it is broken down 5 times, so that you get 5 bands, 0 to 20. Then you have 20 to 40, 40 to 60, you know, like that, until you get to 80 to 100.
Yeah.
So then, what happens is that what is given there is to score those particular items. If you have this is the score. If you have TV, this is the score. If you have a mobile phone, this is the score. If you have the sofa set, this is the score. And so when you use those kind of items, then it will be able to help you gauge what is the score for each household. So you know, if in mathematics, if you have to deal with the cumulative graph, then you'll be able to plot them and see where they are falling. And so then you'll be able now to see who are these fellows in this lower group, which ones are in this middle group, and until you get to the top. So all it means is that most of the items that were used to compute the wealth quintile were not really common in a place like Turkana. And it does not mean that those who are the 53% that we reported to be in the upper quintile are really rich. Not that they are really wealthy, but if you compare their living status with the 80%, then they are a little bit better. Okay. They're in a better socioeconomic status than this other group.
All right.
So that's what it means. But there is also the element of the calculation of the poverty numbers, which we do through the Kenya Integrated Household Budget Survey. We do it every 10 years, so we are now planning for the next one, which then should also be very resourceful to the country once we do it. And then we have what we call the Kenya Continuous Household Survey Program, CHSP, which is also giving us these numbers basically every year. And now the approach to that is now totally different from what we have taken on this one, because this is based on the items at the household level.
Yeah.
But the other one will now is based on the income levels of the individuals in households.
Okay.
Yes.
All right. Gentlemen and lady, we are running out of time here, but I'd like to give you each a chance for closing remarks, just about a minute. And Sheikh, I'll start with you, and you can talk about this issue of migration, one thing that we have not really touched on as your closing remark.
I know migration is very important, but there are 2 things I want to talk about.
Okay.
One is the issues to do with, this survey also looked at issues of chronic diseases and issues to do with there was also the anthropometric measurements that was undertaken. So, but focusing on the chronic diseases, it showed that, especially in something to do with cervical cancer, cervical examinations and breast examinations, the number of women who are going for those services are very few, around 14%. And especially even when you look at hypertension and diabetes, again, earlier seeking of diagnosis is very rare. So I think those are an area that as a citizen we need to really emphasize on how to go for earlier diagnosis and earlier examinations. Okay. The other one is stunting. I think stunting we have done very well. We have reduced the prevalence of stunting, but still those figures are very high. I think that is around 18%. It's very high. But on migrations is that I think it's again about the youth.
Yeah.
As Dr. Mott has explained, this country we are in what we call in a transition. We are a very youthfully, we're moving from a child-based to a youthfully population.
Yeah.
This is what we call now, what we need to do is heavy lifting as a country. We need to do what we call accelerated economic development. This is why we need to invest in our youth, in their health, in their education, in their governance, in their skills, and create job opportunities for them, so that in the next coming years, this number of youth are able to do the investment. What we have seen in the Asian Tigers, they did what we call accelerated economic development in a short period. And that's where we are as a country today, that at least this is the time that we should sacrifice for future generations. Okay. And this is the time to do it.
All right. Dr. Moth, closing remarks?
Before I close, there was this item you mentioned and you discussed with McDonald about insurance coverage, I think, which is very pertinent in terms of the dispensation that we want to take forward going in terms of universal health coverage. We've made progress again in 2018. That was about 19%. Now it is about 26%. And most of the insured are actually insured under the National Health Insurance Fund. And that is why it is fundamental that the government makes the necessary reforms in NHIF to be able to make it a strategic purchase of healthcare services. We need to be able to inspire confidence, people's confidence in NHIF going forward. More so that our target for social health insurance is 85%, meaning now, from now in the next 6 years, we need to do like an average of 10% coverage every year. 10% out of a population of 50 million is covering 5 million people every year. So it's a tall order, but we are up to it, and it is through universal health coverage that we can be able to bridge the inequities and disparities that we have seen, especially from the hotspot maps, which were beamed today at KICC when the report was being launched. But in closing, is basically to say that we have made progress as a country. We've done well, but we still need to do more. We really need to be able to look at it with an equity lens so that the northern arid lands can also be able to enjoy or be at par with the rest of the country. Number two, in terms of my closing remarks, of course, is the clear disparities, inequities that exist, and also inequities in terms of socio-demographic. The rich, the quintiles that you talked about with the McDonald. Again, if you look at their parameters, in all of the indicators, they tend to perform well. And finally, is the catalytic effect of educating the girl child. Yeah. The multiplier effect of that is huge. Okay. So let's keep our girls in school.
All right. Betty, closing remarks?
Yeah, excellent. Actually, just picking up from let's keep our girls in school. I'm so excited to hear that from Dr. Emma.
Yes.
And I would like to speak very briefly on FGM and say that this report speaks to reduced numbers. Yeah. That's really something to celebrate about. Looking at the last KDHS, where we had FGM rates at almost 38%, now we're talking about 15% and going lower. Yeah. And out of the sampled men and women, we have 94% of the women and 98% of the men saying no to FGM. Actually, the men are more, and that's really, really encouraging. It's a retrogressive culture. It has a lot of health ramifications, and I'm very happy that we're saying no to it.
Are we likely to achieve the 2030 plan of zero FGM?
I can see us achieving that. Yeah. Oh, it's so exciting for me. Okay. Really exciting. To my closing, we have a new government in place. It's talking about the bottom-up transformative economic agenda, the BITA. And I'm looking at the Kenyan woman, looking at the statistics in this report, and looking at the fact that they can access smartphones, mobile phones, digital applications, and now we have the recent launch of digital services for payment, for accessing government services, and so on and so forth. I can see a better space for the Kenyan woman. Okay. And of course for the Kenyan man as well. Only that the men have more mobile phones as per the report. So I'm talking for the woman and saying there is really high hope for the woman in terms of engaging with the new transformative agenda. Okay. Secondly, I'd like to say that in bridging the gap and having this empowered woman and looking at the 2/3 gender rule, which is really the big agenda even for this new government, I can see hope in our attainment of the same. Because with more empowered women, we can bridge the gap and have more in leadership and taking spaces where they can make decisions. Okay. And therefore, this report spells much more hope going forward as opposed to where we are coming from.
Okay.
Yeah.
Thank
you. So, you see, Trevor, part of my work is to disseminate statistics.
Yeah.
And so with the good report that we have just launched, we have already uploaded the volume 1 and volume 2 on our website. We are going to do it in many, many websites so that people can easily access the information. We are also careful to have the data itself. The data that has been used to produce this publication is also going to be on our website. There's a portal called Kenada, Kenya National Data Archives. So as many people as possible will be able to get this report for use. And then we also have a dashboard that has been developed specifically for this exercise, which then allows users to interact and generate more indicators using that particular dashboard. So it is already on our website. Then we have the posters, which are speaking to various thematic areas. For example, there is one that is on demographics, there's one on health, there's one on domestic violence, and then there's one on the characteristics of the population, both at the individual level and the household level, which we have also produced alongside these ones, so that Kenyans can easily get good usage of the report. Then the last one on that is we have the fact sheet. The fact sheet is given for each and every county. We have 47 of them. So the first page gives a lot of statistics for that particular county. Then when you go to the second side of it, it gives comparison with the neighboring counties, which then would tell you where you are in your own county, what is the performance in terms of those indicators and against your neighbors. Very, very useful. So the last thing that there's a wall chart, and the wall chart is having all the 47 counties against a number of indicators based on thematic areas that we have picked, and it is able to compare all of them across. So we have a lot of information that has been generated from this report, which Kenyans really need to use. Okay. The last bit that I would want to speak to, it is very expensive and time-taking to come up with this kind of a report. And so there are a number of indicators that have been generated at the county level, which is meant to be helpful to the counties. Remember, health is devolved. Health services is devolved. Yeah. And so we need to have counties, the county government, making good use of this report so that they can now put a shilling in the right area that will make a difference. All right. Thank you.
Thank you so much for making time, ladies and gentlemen. McDonald Obudo, Director General, Kenya National Bureau of Statistics; Betty Sungura, CEO, National Gender and Equality Commission; Dr. Patrick Amoth, Acting DG, Ministry of Health; and Dr. Mohammed Sheikh, Director General, National Council for Population and Development. Ladies and gentlemen, I can promise you one thing. This is a 660-page document. We have another one which is 400 pages as well. That is Volume 2. Over the next few days, we'll break it down for you in our subsequent bulletins. So do not worry, we cannot unpack all of it in one show, but over the next coming days, we'll delve into it and tell you what is important, where, and what the findings say, all right? On behalf of the entire team that made this possible, my name is Trevor Ombija. Have a good night. God bless.